Good afternoon, everybody. Thank you for joining. We're just waiting for everybody to join. Good afternoon, everybody. Thank you for joining. We're just waiting for everybody to join. Thank you, everybody. We're getting quite a few people joining us now, and we're just waiting for a few more to join. Thank you very much. Won't be long before we get started. It'll just be a couple more minutes to allow everybody to join us. Just to remind everyone that everyone is joining on mute, and we will be using the Q&A function for any questions. This video is being recorded, and we will make sure that you have the link available to you and for anybody that isn't able to join us and who has signed up. I'd like us to go to slide 2 now, please. This is just our quick tips for a successful webinar. We're going to use the Q&A function, and we will be introducing people as they come up, and we will have a short Q&A after each speech, but we'll do the majority of our Q&A at the end. Right, I'm going to ask our chair for today, Ian Bernstein, to join us and introduce today.
Thank you. Welcome to this seminar on making and embedding transformation during restitution of NHS services following the COVID outbreak. This is one of a series of webinars from Connect Health to support improving musculoskeletal health across the whole population in England. Now, we're expecting about 120 people today. We stand at a crossroads, and I look back remembering colleagues and family who've been very ill or sadly passed away during COVID. We could stand still and face the heavy burden of both musculoskeletal and mental health that accrued both before and during the COVID outbreak. And we still haven't solved the financial challenges facing the NHS despite pledges from ministers. Or we could move forwards embracing the change during the restitution of NHS services with collaboration rather than competition driving transformation. We've had lots of discussions at NHS England about how we must do something and we must do something different. Here today, we have 5 distinguished senior managers and clinicians from across primary, community and secondary care to share their ideas and stimulate discussion about how to actually and successfully transform services. My name's Ian Bernstein. I'll be chairing the session today. We'll be asking each presenter to speak for about 5 to 7 minutes. Then there'll be a short section for a few minutes just on clarification questions, and then we'll take the majority of questions at the end of the presentations. So it's my pleasure to introduce our first speaker, Sir James Mackey, Chief Executive of the Northumbria Healthcare NHS Foundation Trust, will be covering integration across primary, community and secondary care. Thank you.
Thanks, Ian. It's a really good introduction. I just want to reflect a little bit on where we were pre-COVID and what COVID's taught us, and then a little bit about where we are now. Just left a couple of discussions earlier on this morning where we're working through how we will get access opened up and back in the game in lots of services that have been running at a very low level over the last few weeks. I think first of all, when the commentary's going on about where we are now and the projections on long waits, etc., it's important to remember that the NHS had backlogs before we went into COVID. So we're already running a bit hot. There's lots of really helpful signals and promises about resource from government, some of which have just recently come through. But there's a recognition that the NHS was running at full capacity already at that point. It was going to face a pretty big challenge to deliver what we wanted to do in terms of access times and some of the quality improvements that people wanted to deliver. And the COVID lockdown is obviously been very successful in avoiding a collapse of the health system, but has created very, very clear backlogs and concerns about access to care in lots of different settings, ranging from people who've been at home the whole time and have had an illness or a presentation and been too worried about seeking access, right through to people who've been diagnosed just before COVID and needed an operation, and that hasn't been possible until things started to step up and people felt safe again. So we're all struggling with this now, and I think from our point of view, it was fantastic to see the agility and freedom from NHS staff under a very tight command system in the early days, make loads of changes in a very short space of time. So in our organisation, most of our changes took place over 2 days as we got ourselves ready to stand ready for the surge. So there's 2 days there that will stay with me for the rest of my life, where we'll move services all over the organisation, change pathways, change models, flexed staffing, got people into areas that they hadn't worked clinically for many years, etc. And a general sense of people really pulling together. And saw through the whole COVID surge and are now really motoring on in terms of trying to restore access to services and hold on to some of those gains. So the big gain everyone will talk about all the time is the digital access thing in primary care and in an outpatient setting. I'm slightly worried about that now, and that it's seen as binary, either everything goes back to how it was or everything stays as digital, and we're trying to encourage people now to add a nuance, add a thought process into that, and make sure that people who do need to physically see a human being are seeing a human being, etc. So like probably everywhere in the country, people are going through those processes and navigating the whole PPE, distance and issues, etc., to the testing regime, etc., to make sure access is restored appropriately and safely. The bit I wanted to really touch on today was in all of this, we've created and exacerbated a lot of risk in a community setting, and one of the really powerful things, as well as the kind of staff agility issue I mentioned earlier on, was people really pulling together in place, primary care, secondary care, council, social care colleagues, the business community, the public at large. And from our point of view, it looks like PCN's really got a really big step up through COVID. So it formed well in our system. They've been really getting off the ground really effectively, and COVID gave them a great purpose, a centre stage, if you like. So we're in the process now with other colleagues and partners to just see how we expand and extend their ability and capacity to do what they need to do in their locality, and really focusing on how together we identify risk and look after pretty vulnerable people, keep them safe, make sure they get the access they need to. But really importantly, I think learning from the whole COVID experience, avoiding dragging people all over the place for access to care. And pre-COVID would set out some expectations here to try and reduce miles travelled for patients. In 1 month, well, for April and May that's just gone, we've managed to reduce miles travelled by over 600,000 miles for patients by really trying to work together and look after people in a community setting, and also really embedding the kind of digital transformation that we've seen over this last few months. So when you try and stand back from that and think about, what are we really trying to do now? We've got a few months to try and get on top of this and make sure that we're in good shape going into winter, accepting that we've had a really big shock to the system and we've created lots of backlogs and lots of risk has been opened up during that period. So we really need over this next couple of months to be getting really organised about getting on top of that, so we're in good shape to withstand winter. Hopefully not a second wave, but nobody really knows. In terms of embedding change, I would encourage people to just really thoroughly challenge what we used to do, the things that we did in a rush and whether they're actually working, and constantly be testing and refining those things, because a lot of these things were done in a real rush, weren't fully tied into formal systems, and I think really importantly, make sure that they're actually working for patients and staff as well, because some of them were really done in a rush. You can see now a little bit of an reaction in certain quarters about everything being digital, for example. So these things only work if they're actually meeting people's needs. And in that, it's probably 4 points I'd like to end on. Let's all be really objective about what works and what doesn't work. One of our barriers all the time is we get very wedded to traditional models and ways of working, and we blew through an awful lot over those first few days of getting ready for COVID. Let's stick to the facts and the evidence as well. So let's gather the data and the intelligence on what's happened, what's working, what's not working, what needs to be refined. So on that digital thing, we're putting a huge effort in now to patient experience to make sure that it is actually working for patients. Third key point is really let's maintain that agility and flexibility, that liberation of staff that we saw in extremis during COVID, and hang on to it, because we've become very rigid and very specialised and very siloed pre-COVID. So that's a real benefit I think we really need to try and hang on to. And then finally, just to wrap up, these things only work if they work for patients and staff. So let's use the intelligence, let's seek that out, let's make sure we don't embed a change that's there for convenience of an institution or a clinical team or an individual at the expense of the people that we're here for. So they're the key things from my point of view. Very happy to open it up and address any questions.
Great, thank you, Sir James. There's a couple of questions come in. The first is, what's the biggest thing that you've learnt during COVID that you think you're going to carry on with? Obviously early days at the moment, but what's your...
So I think in the early days, I think the digital transformation would have probably been the thing that came out of everybody's mouths there, especially from an outpatient's point of view or a triage point of view, etc. I think I was talking to my chairman earlier on. Early doors, we installed simple things. It's a non-clinical thing, but it's very effective. Sinks at every front door of our hospitals, and masks are issued there, etc. And I think going into a normal winter, they'll be incredibly helpful. So actually, there's a very simple, practical innovation there that in a normal, risky norovirus flu kind of winter thing will be very important. So there's two practical innovations there. I think the real issue though has been the everybody pulling together with a common purpose, which created a lot of flexibility. People felt liberated, oddly, in a very command control system. For people to remark that they felt more liberated, I think is very powerful. That's the main thing from my point of view, and the thing that we've got to hang on to.
Lovely, thank you. So just a couple more questions there. You mentioned that there was more collaboration in spite of the command and control structure. Are there any highlights that you can think of, or anything that was pre-existing that's worked really well because it was there already?
Yeah.
In terms of
so
collaboration.
we benefit from generally very good relationships in the North East. So we're sort of odd combination of people who are hugely competitive with each other, but know when we need to pull together. And I think that really showed. A good colleague here who runs one of our councils reminded me early doors in this process that you make all of your friends before a crisis. They're very hard to make in a crisis. And I think that absolutely, shone through. So what we had was a really strong place-based focus. So hospital, community, primary care people, council people pulling together in communities. And then across the North East, largely through the critical care network, very, very structured processes to help each other out. Daily calls of chief execs, daily calls of COOs, clinical colleagues, etc. Watching the data every day, and everybody being ready to step in and help each other out if somebody got into trouble. So we had collaborations going on lots of different directions there. I think generally people are quite consistent in describing similar things around the country. So we would say that worked very well here because we generally work well together anyway. Somehow COVID managed to create that in places where they weren't getting on well. So I think again there's a bit of learning in that.
Yes, absolutely. I think it's key to make friends, as you put it, before there's a crisis. So a good take-home message. And the final question, you mentioned something early on about being able to see a human being. This is sort of patient perspective. How are you going to ensure that going forwards?
What we're doing now, I did a bunch of staff engagement things last week and the week before, largely through Teams, but also some physically distanced ones as well. And the most powerful message in that from people who are working with children, autism, child protection, community people generally, was, and some hospital clinicians, was the need sometimes to just be able to make a broader assessment, have a broader engagement that you just can't do in front of the screen. So what we're doing is just encouraging people team by team, case by case, patient by patient, to make a judgment. We want to hang on to the technological gains that are hugely beneficial. They can really help with the backlogs, etc. But sometimes you've just got to stand back and you have to hands on a patient, or you have to see a broader environment. You've got to see family interactions, the home environment, those sorts of things. So what we're trying to do is to just stimulate conversations where people don't get locked into a path that's just really not working for them. And also, we really rely on our patient and staff experience data. So that ability to capture those interactions and see what the patient and families actually think will drive further change for us.
And I think you've hit the nail on the head there. There's two things. One is the patient and staff feedback. The other is making sure that the systems do actually allow patients to express a choice. It's very easy to shoehorn people into a digital pathway, but there needs to be a sort of get me out of here button somewhere along the way. We've got a question on the portal about how is morale. I'm presuming this is staff morale. Any sense of what's happened as the crisis has passed and people are now facing the reality of long waits and different ways of working?
At the beginning of the first sort of clinical contact with COVID, we changed our staff experience program to a thing called Corona Voice. We do a weekly interactive troll with staff to gather their thoughts. So we've been tracking that right throughout. And generally morale's held up very well. I think people pulling together has been really powerful. Obviously, a lot of people frightened. It's depending on where they worked. A lot of anxiety. Our main morale issues, anxiety issues, etc., were for people who are remote from work, who are working from home, or who are shielded. So there's a lot of complex stuff going on with those people. So we're working on that now. The people who were absolutely right at the front edge of this, oddly, seemed to have higher morale and felt more kind of together, etc., because they were well protected, they had a team camaraderie, you know, etc., all the adrenaline of getting through it. And I think what we're a little bothered about now is you can see people are very tired, whether you've been working very busy shifts in ED or ITU, or you've been shielded, or you've been working like we have, sitting in front of the screen day after day. It's been a very, very tiring few weeks, emotionally, physically, you know, etc. So somehow we need people to be able to get some rest in the next few weeks and get ready for what could be a tricky winter.
Great. So James, thank you so much for your time and great presentation. I'm going to move now to our next speaker, who's Mr. James Benson, Chief Operating Officer of Central London Community Healthcare NHS Trust, who's going to look a little more about integration from a community perspective. James.
Thank you, Ian. Can I have my first slide, please? I think most people will recognise that during the pandemic, and certainly today, community services have continued to support an awful lot of vulnerable people at home. The vast proportion of our work for adults and children is around supporting very vulnerable populations and providing quite interventional services. And I think we've had a significant sea change in the way we deliver and understand community care, not only in terms of MSK, but also general community nursing, general health visiting, and some of those big service lines. But the biggest delivery that has occurred is our response with colleagues that Sir Jim identified around discharges and really thinking how we manage flow across the system. My organisation works in 4 different STPs, and collectively we've been looking at what that discharge offer is going to look like moving forward. Because even though I've been in this field for a very long time, our ability to facilitate discharge, I have never seen such a sea change in ability to keep people out and get them home. And we as community providers understand the complexity of the system in which we work in the out of hospital space in ways that no nurse on a ward or junior doctor ever would, nor should we expect them to understand that. At the same time, we've been able to maintain services to very vulnerable populations. During the height of the pandemic, we were still seeing around 3,500 patients a day as an organisation, be that face-to-face or virtual. Our virtual offer expanded significantly in terms of children's services. So health visiting obviously went virtual, and we have been able to maintain a number of our statutory checks. And that was surprising to me in as much as we had at one point over 17% of our staff off. But what was interesting when I started to look at the data was because we now had people working from home, we were able to support people who historically had been ill, colleagues, to start to come back into the workplace and deliver services in ways that we had never imagined before. And whilst my sickness for COVID was going up, my sickness for other conditions was actually going down, and we were able to return a number of long-term members of staff off sick back into the workplace in ways that we'd never considered before, because the offer was fundamentally going to be different. And colleagues, I feel, wanted to be part of the work of the organisation. But one of the big challenges that I think colleagues will understand is that the vast proportion of the work of community services is direct interventional care. It's very difficult to do leg ulcer management remotely. It's very difficult to do diabetes support for someone who is at home remotely. And what we ended up doing is really think from a logistics point of view, what is the best way of getting our staff to visit people at home? Some colleagues will recognise that we provide services across 11 London boroughs and the county of Hertfordshire. We're in central London, we go right out into regional areas, and the offer and the way we do things is very different. So at one point we were literally driving our district nurses around in central London. Their productivity went through the roof, and in fact in one of my teams they were happy to report that during the pandemic they had not failed one visit. They'd all had their lunch and they'd all got home on time, which from a chief operating officer point of view, I was entirely surprised with, and it's because we had to consider what is a different way of delivery of healthcare, and part of that was for us bringing in drivers. But if I think about some of our clinic-based services, we've had to really think who and how can we deliver virtual care. For our MSK services, that's something we've been doing for a while, but really then thinking who are the sorts of patients who we might need to extend the virtual offer to, what does that look like, and who are we going to need to keep on our waiting list, because as Ian has identified, there are some of our patients who will need to directly come into clinic, and that hasn't been able to be delivered whilst we've kept services down. But as Sir James identified, we have been doing an awful lot of work about really thinking how we integrate our services at an ICP level under our banner of integrated care systems. And I think all of us will recognise that our joint working directly with primary care as part of a PCN has started to open up a conversation about how do we run MDTs, what sort of staff do we need in our MDTs? If I think about first contact physiotherapy, what is that going to look like in terms of not only an MSK offer, but a general rehabilitation offer for our populations? Next slide, please. So part of that provision of care moving forward is really for all of us to consider what is the integrated, universal and direct care offer at those local networks within integrated care partnerships. We have 58 different ICPs that we work with as an organisation, so you can imagine the scale of different localities or networks. Fundamentally, all of those are similar and yet different, and therefore what we're really considering is what is the case management approach? How are we going to run those MDTs? What is the operating framework where we will be able to deliver a planned service in the community, and how do we escalate those into a rapid care offer that can respond within 2 hours, that can mitigate the district nurses being pulled left, right and centre, but also helps our discharge offer directly from acute. Because as we are going to need to discharge patients more quickly and more consistently as our acute colleagues stand up some of their elective care, we're going to need to be able to respond in a way that we haven't done before, and that is about accepting a single assessment process, facilitating and supporting people directly in the community, and really working with not only primary care and the voluntary sector, but our local authority and county authority colleagues to understand what an integrated offer is between reablement and intermediate care services, and how do they fit specifically with some of our specialist therapy offers. The other big component of that is really the challenge around what is going to be our bespoke offer to residential and nursing care facilities. Many colleagues have probably been very saddened by some of the outcomes that our residents and families have experienced in care homes. And I think that is largely due to the fact that, especially for nursing and continuing healthcare, there's always been a bit of a to and fro around whether or not specialist teams should be providing services in there. And I think that has passed. We will and should continue to recognise that no matter where people are, we will need to provide them specialist advice and support. And I think we're going to need to consider what that looks like, especially around therapies, be they MSK or general physiotherapy, into those homes to keep people mobile. Part of that is therefore around what this offer around discharge and hospital prevention is going to be. And certainly I think we will need to bring together not only the rapid offer for general community, but also for our care home teams, because that's where we see the biggest number of admissions directly into acute care. And as Sir James has identified before, we are going to need to go around and consider what this enhanced digital offer is for all of our services. And we've got to be clear that it promotes wellness and self-care. It must meet the needs of our population. It cannot be just that we're going to offer something virtual, then to see the patient face to face, because it doesn't make any sense to offer it virtually in the first instance. But at the same time, there needs to be a recognition that providing a virtual offer will potentially increase our responsiveness to patients, will provide them with a sense of direct support. As I said in the opening part of my talk, our health visiting services have gone largely digital because of the ability to maintain statutory checks. And what we have managed to do is move that offer from a sort of standard, dare I say, 9 to 5 Monday to Friday, to an offer that extends well past those hours, well into the weekend, and allows a virtual offer for mums, dads, families, carers to ring in, to dial in, to provide a level of digital backup and support to families. And I think we will start to see, and I'm expecting to see in some of our emergency care boards, an impact of some of those offers, especially for vulnerable children, and what that looks like in terms of direct admissions into acute care. Clearly, there is a huge piece of work that is going to need to be done in terms of restoration of community services. I recognise that we do not simply just provide domiciliary care, and later on, I think one of my colleagues will be looking at the return of elective care, but we will also be doing that in communities, and we're going to need to understand what the impact and the relationship is between not only the acute restoration of services, but what the impact is in terms of discharge flow and the way we deliver care. Thanks, Ian.
Great, thank you very much, James. We have a couple of questions that have come in, and I'd just like to remind colleagues on the call, please do submit your questions through the Q&A so that we can pass them on. So the first question I have for you, James, is how have staff adapted to using digital consultations?
So I think our staff have adapted in ways that I thought they probably wouldn't. Because there was no option, we literally spent an awful lot of time, deploying kit to staff. We were already on that journey in and of itself. We have a digital offer. We have no paper records for our community services. So staff are very used to using their laptops. What we ended up doing was having mass training events around how you practically do a consultation virtually. And we didn't do that from the point of let's bring someone in. We did do some training via our CCIO, but then we held webinars where staff were able to share their own experience. I am the SRO for our Disability and Awareness Network, and I chaired a meeting with our colleagues who have disabilities to understand from them what was working and what was not working. And it was really helpful for that to be shared with wider colleagues in the organisation.
Great. And any lessons that you'd like to share more widely?
Yeah, so I go back to the lesson I flagged before. Community services, often have a number of staff who are unable to work because of a number of physical reasons. The physical work of the district nursing workforce is significant, the same as our health visitors, and we have a number of older colleagues who I feel we haven't been able to support in the workplace in ways that we could, because they might have MSK needs, but trudging the streets of central London day in, day out is not the easiest. And therefore they've been off sick. And I was so impressed on their ability to want to come back to engage in the delivery of care, because we now had a way of doing it. We could listen to them, we could work with them to provide an offer that we had never done before.
Brilliant, James, thank you very much. We have got some more questions which we'll come back to at the end. And I'm going to move now to Mr. Dinesh Nathwani, Consultant Orthopaedic Surgeon and Honorary Senior Lecturer at Imperial College Healthcare NHS Trust. And he's going to talk through, from a clinical perspective, the development of a clinical reference group to support elective recovery in North West London. Dinesh.
Hello everyone. Thank you, Ian, for inviting me to give this talk, and also to the Connect Health team. Very interesting concept coming out, and it's really good to hear that there's been so much clinical integration across specialities and across systems, which is one of the big benefits of the COVID crisis, really. Our orthopedic surgeons had to suddenly become ventilator experts, and we were also put into medical team pods to start looking after the respiratory ill patients. So the redeployment has been really interesting, and it's shown that some staff are very, very good at redeployment. In fact, some of the nurses that we did send to ITU and to the emergency department are not keen on coming back to our service. So it's good news that, that such integration has happened. So my remit today is to let you know what North West London is doing around the transformation of clinical services across the sector. So I'm the North West London Orthopaedic CRG lead, which I share with Ian, who's the primary CRG lead for primary care across the sector. And both of us have been involved in the North West London MSK Clinical Network, which we both co-chair, which I'll come to later. Can I have the next slide, please? So obviously the incident has created new challenges, but new challenges has created new opportunities for us. So transformation has become almost a buzzword throughout the whole system and throughout the whole hospital. At Imperial, we have 3 very large trusts, and we became very site focused, and we had site meetings every day, which seemed to work really, really well. And it was amazing to see colleagues who would have shared the same floor or the same corridor before suddenly become partners in a delivery of care, even though it's different specialities. Prior to COVID-19, orthopedics was very much focused on the clinically led programs such as GIRFT, getting it right first time. And the CRG system that we've created now does have a GIRFT representative through every speciality. So the reference groups that have occurred throughout Northwest London really are the vehicle through which this change will be designed and implemented, and hopefully clinically led and focused. So that's how the ICS has seen the transformation across Northwest London occurring. We're focusing on high volume, low complexity surgery. So the low complexity bit is a bit of a challenge, but high volume is certainly something we will need to consider looking at the waiting list that we have accruing over the next few weeks and months. Next slide, please. So our recovery and transformation program is a NHS London-wide regional program. There are 5 sectors. Each sector has been challenged with looking at their high volume elective surgery, and 6 main specialities have been chosen, which I'll show you in a second. We're utilizing the GIRFT principles throughout to look at best practice, to look at the best practice throughout the country. I know Northumbria has got some excellent results with the GIRFT methodology, and it's important that London keeps track with what is happening throughout the country, and we share the innovations that are delivered. Next slide, please. So this is the general structure of what's been created throughout the Northwest London ICS. You can see the 6 providers: ENT, general surgery, gynecology, ophthalmology, orthopedics, and urology. Each of these CRGs has a clinical lead in secondary care and also a clinical lead in primary care. So in orthopedics for Northwest London, it's myself and Ian, and we would report to the lead provider steering group. And Mirav Dover, who is also on this program, is the gold SRO for the elective program, and she'll give you more details on what happens once we've passed information across to the lead provider steering group. It then goes to an elective care board and then to the CEO. So the structure is very simplified and hopefully will lead to quicker decision making. Next slide, please. So this is how the lead providers were selected. We looked at all of the GIRFT reports and found data from the GIRFT very helpful. From the Northwest London sector perspective in orthopedics, we had a very mature MSK clinical network, and therefore the providers were chosen, or the CRG leads certainly were chosen because of the maturity of this clinical network. The head of service leads for each of the 4 or 5 trusts are also in the CRG, and they all report on a regular basis to discuss the transformations that we are trying to deliver. And then the decision goes through the integrated care system, gold group, and through the CEOs. So the system is becoming much more flexible and versatile, and hopefully the delivery of the transformation will be quicker. Next slide, please. So obviously we have to engage clinical and managerial leaders. We can't effect change without integration of services across the level. We need to get the clinicians, the primary care clinicians and the secondary care and community care systems working together. And I think that is one of the main roles of the ICS, to try and bring everything together, to reduce length of stay, to have patients in hospital for less time, but making sure that they're equally looked after in the community. The lead provider that we've allocated to each of the specialities is not necessarily the provider to be the sole provider for the activity, but just the one that consolidates the primary and secondary network. Next slide, please. And so obviously there's lots of stakeholders. The public are extremely important in this. Once the clinical teams have decided which direction we wish to travel, then all of these stakeholders will come in and public engagement will be an absolute must. But across London, there are lots of providers and it may be a chance for consolidation of some of the elective services. Next slide, please. And so here's a challenge. This is a tsunami that's awaiting us. If you look at the waiting list now, 48 weeks to 51 weeks, we have a large number, and there's a huge number between 28 and 30 weeks that are about to tip over into the 52 weeks. So it seems that all the good work that we've delivered over the last 5 years to get waiting lists down is likely to be undone because of the last 3 or 4 months of the COVID crisis, and we have to try and meet these challenges. I think when we have stakeholder engagement such as the public, it's important to show them the problems that we've got with the waiting list, and hopefully the patient engagement will be much more secure and beneficial. I think everybody has realized that this is a time for change, and maybe we can deliver it this time. And I think that's the end. The final slide.
Great, thank you, Dinesh.
Yep.
I have some questions for you. So the first is, in terms of this recurring theme of digital offer, which you've heard from our other speakers, mixed feedback from patients, so sitting in primary care, mixed feedback from patients about their experience in secondary care. And James Benson mentioned about staff training. Can you tell us a little bit about the staff training that you would hope to see or has been rolled out in terms of telephone and video consultations across acute trusts?
Yeah, so I think it's been implemented very, very quickly, and obviously different systems are in place. So therefore, we have an electronic patient system at Imperial, but we've used the Attend Anywhere platform for the digital video consultations. I think, as you alluded to before, it's very important that patients have a choice, and trying to get each patient on the clinic list to decide whether they would want to like a video consultation or a telephone consultation is quite challenging. And maybe some of the other apps that are being introduced for direct patient contact will help with that. But the feedback that we've had from the video consultations has been excellent, because we've had the imaging at hand and we're able to share screens with the patients to show them exactly what's wrong with their knee or their hip, and actually show them on the MRI scans the detail of the pathology, which sometimes in a very busy 50 patient clinic, you can't show every patient what's wrong with their pathology. So it does provide us with an opportunity. The interesting thing across Northwest London sector is the conversion rates for surgery lay around 30 to 35%. So there are a number of patients who digital and video consultations are likely to stick. At the moment, all of the elective consultations we are doing are either telephone or video, and the ones that we would like to see face-to-face are the ones going for surgery, which is 30% of patients currently. But we will need to give some thought to that.
So 2 more quick questions, if I could ask for a brief response. So you mentioned about conversion rates. How do you see collaboration with community providers developing to improve that? I mean, the sort of national targets over the years have been around 70 to 80% conversion rates, and we've struggled for years in London to get to that.
Yeah, I think the digital transformation is going to help with that. We run mass clinics within the Imperial structure, and there's no reason why we couldn't connect the primary and secondary care referrers together, because a lot of the referral quality is very, very high now. And we could easily link up secondary care physicians to that network in joint consultations with patients. So I can see a very, very good future in terms of connecting the primary and secondary referral systems.
Brilliant. I'm going to leave the questions there and move to Mrs. Merav Dover, who's Chief of Staff for the Northwest London Integrated Care System. And she's going to give us a little bit more of a flavour from a managerial perspective about transformation in elective care. Merav. Sorry, we can't hear you yet.
Okay.
That's it.
Great. Okay. Thank you all very much indeed. And thank you, Ian, for the invitation to come and speak with you. So I'm just going to run through a few things with you. So first of all, who am I? I've worked in North West London now for 3 years for all our chief executives and CCG leads to really work on the transformation that if they do together will make a really important felt difference for patients. And when COVID started, I was asked to, I'm still not sure if it wasn't instructed, to run Gold Command across North West London. And just to emphasise, that's a population of 2 million people. It's 8 boroughs. It's very diverse population, highly deprived, and we definitely were hit the first and the most in some of our hospitals. We did a fantastic job in the NHS generally in keeping patients and staff as safe as possible, and we I think this was true nationally, and I think we accelerated change in the way that we've heard from lots of people. And I just want to first of all touch on why was it possible during this terrible time of immense suffering to really move forward the pace of change that was required. So I think the first thing I'd say, which in part reflects what Sir Jim said, was we had already invested a lot in our relationships and trust. So as certainly at a chief executive level, with James Benson, who you heard from before, is at a COOS level, with our clinical directors, they knew each other. We had argued together, things had been contested, we had shared good times and bad times, and I think that development of the trust that was made could not be underestimated in terms of the ability to come together and do the right things for our staff and for our populations. The common purpose we've heard a lot about, and I would just emphasize again that the bit about the common purpose that was so important was this was not about people were no longer seeing what's in the interest of my organisation, but what's in the interest of the population at large. And that meant absolutely crossing organisation and indeed specialty boundaries. What we always knew, but what was absolutely demonstrated was the importance of good clinical leadership, and we had good clinical leaders in abundance, of which Dinesh and Ian, who you've heard from already, are 2 of those. We worked 7 days a week. We started very early, we finished very late, and the drumbeat of every day through Gold Command was it started with the clinical leaders. And it started with the clinical leaders looking at meaningful data and deciding on the basis of that data what we were going to do. The day ended with the chief execs, and of course I could bring that forward if needed to. They made ultimate decisions, but it was that drumbeat of the clinicians meeting first thing in the morning that drove the change and drove good change. On the data, the bit I just want to emphasize on the data is we're not short on data, we're just short on insight and it being meaningful and it not being contested. And one of the ways I sometimes think things are beginning to unwind again is because we're contesting the data rather than saying what do we actually need to do. And the thing about that COVID showed us is that when you get very meaningful data that everybody believes in, it drives change. So this data was incredibly meaningful. It was telling us how many patients need ventilators, how many do we think are going to need ventilators in 5 days' time, how many ventilators have we got, and therefore what are we going to do and how are we going to move patients and staff around the system to keep the maximum health outcomes. And we just have to be rigorous now in making sure we have one data set that is not contested and that is useful. Why else were we allowed to, did we make changes? I think that governance was really interesting. It did allow very quick decision making, and people loved that. You know, it was just a pleasure that, you know, what you said in the morning, by the end of the day, you had been done. And it just energized people. We were shattered. We were not sleeping, but we were so energized by you know, we all came into the NHS to make a difference, and we could see that difference we were making at the end of every day. The other bit that I think was really interesting on the governance, and certainly in the way I ran Gold, was actually I did not care about what band people were in or what hierarchy people were in. You just spotted the really good people who made a difference, and they came to the fore. They just rose up. And they got things done, and there was something about that, not having to go to somebody's manager and somebody's manager's manager, which was really interesting, let's say. We switched off the status quo with COVID. You know, patients without COVID just could not come into the hospital. Relatives could not come in. So we had no choice but to do things differently. And I think that's really interesting. I mean, one of the things, Dinesh, that you and I have spoken about was that for years we'd spoken about virtual fracture clinics. We had the data, we knew it was the right thing to do, but we did not manage to get virtual fracture clinics on each of our acute sites across northwest London, and now they're there. Now, we had no choice because the face-to-face was not possible. But what's the learning from that? Is the learning from that we just we get to a point where something's proven and you just switch off the alternative. You don't go for that kind of slowly, well, you know, let's just see when we've got enough people on board willing to do this. And then lastly, the point that I wanted to make was about the reduction of fragmentation in provision and commissioning. Now, we had 8 CCGs, hopefully we'll have one shortly. Fragmented commissioning led to fragmented provision, and then of course the providers not working together led to even more fragmented provision. So you can just imagine the complexity that people were having to deal with when it was, say, at ward level. And we very quickly made decisions to reduce this fragmentation. So, for example, we did have 5 organisations providing community services. One of them very quickly put their hands up and said, you know what, we're not great at this. So another community trust, in fact, James, who you heard from, said, that's fine, we're good at it. We'll step in, we'll provide your community, we'll work with your staff, your teams, and we'll provide it. And Imperial, a 3-site really big trust like Dinesh's, was dealing with 3 different community providers. It was a nonsense when you tried to look at discharge. And we said, you know what? 1 community provider for the whole of Imperial, full stop, decision made in 1 day. It was changed. Did people like it? I mean, certainly the recipients liked it. You know, some trusts at some point felt, you know, there was obviously a pang and a kind of, oh, what does this mean for my organisation? Is my organisation losing out here? But that common purpose, remember, that was there, that, you know, very quickly you went back every moment. You looked at the data, you saw people were dying, you knew about your own friends and family who were suffering, and you went, do you know what? It's not about my organisation. Yes, we won't provide community services there any longer. And there were lots of other examples of that reduced fragmentation. Can I have my next slide, please?
So Marav, just to let you know, we've got a couple minutes.
Okay, I'm going to go on to my next slide then. I'm going to jump that one. Because actually I want to focus just a little bit on what our biggest challenges are now. So I think for everybody in the NHS, but particularly in an area like North West London, we know we have to reduce inequalities and increase outcomes. Reduction of inequalities has probably been in every paper there's been since, you know, time immemorial. Have we been very successful in it? I can't honestly answer you that, but all I know is that COVID shone a light on the inequalities in North West London, and it was not good enough. And the real difficulty for us is, in order to really reduce our inequalities, we are going to have to reallocate our resources. We are going to have to put our resources where our communities most need them. And that means you absolutely have winners and losers, and that's going to be contested. The governance, I mean, interesting, several of you have mentioned that. We have a dilemma. We know that it was really motivational to do things quickly. We know there was a lot of patient benefit to do things quickly. And we also know that what suffered in that was some of the engagement and ownership of the changes. And in particular, say, if we're looking at how much did we involve our local authorities? How much did we involve patients in that? And if we now go back to a situation where we're much more engaging of patients and a broader ownership, we will lose the speed. And there's a real challenge to how we get that balance right. We've, of course, you've all got this incredibly complex change programme we've all got now, and planning for this second wave of COVID. So whilst I'm doing all this massive change for the ICS as their chief of staff, I'm also ensuring that, you know, with a second wave, we know exactly what to do. We don't start at the beginning of where we started last time, but we start from all the lessons learnt. Ours is the North West London ICS. I'm in an absolute privileged and honoured position to work for so many fantastic chief executives and clinical leads. And in particular, our ICS chief executive, I think, is second to none. But it does present a complex, uncertain, ambiguous position, because on one hand, we're saying we're doing everything as an ICS. There is absolutely no legislation, and people still have their own trust boards and their own trust accountability. And we are going to have to find our ways through that. And lastly, what I'm going to say is, we don't talk about this very much, but this level of complexity and speed at which we have to do things, if we are, you know, we have eye-watering backlogs, we have non-COVID harm, which is just awful, plus the possibility of, and a very likely possibility of, another surge. That complexity requires us all to really operate at the top of our game. There is nowhere to hide. So therefore, we have to really look after our staff and motivate our staff so they can work at the top of our game, at the top of their game. And I leave you with a question of, we have to also work out what to do and how we move up those staff who really are inspiration at the top of their game, but are somehow a bit embedded and below in the organisation. Ian, thank you. That's what I'd like to say. Oh, you're on mute, Ian.
Off. Okay, Merav, thank you. Truly inspirational. Thank you very much. I want to just pick up one question, which is around health inequality. So most of you will remember the BBC news coverage of the Brent area at the beginning of the outtake, which had something like a 10-fold increase in mortality in healthcare workers compared to the rest of the population. And as you say, it shone a spotlight not just on healthcare workers, but on health inequalities in general. What are we doing during this recovery phase to improve health inequalities? What are the things in place to help us do that?
So in North West London, we're really lucky to have a population health tool. A digital tool that enables us to really see at very granular detail by individuals health status and a whole load of other things. And I mean, Ian, I can see you nodding. So we've got some clinicians who really use it and have embedded it into daily practice, but we've got too many who don't. And so our commitment is to say that in each of our programmes of work, we are going to look at population health management. We're going to look at that tool, it's called WISIC, that drives the information. And from that, we will focus on our priorities and what we're going to do. Our priorities will be signed off by our clinical leads and our chief executives and our COOs. And if they don't meet the criteria of using that tool, and if they don't meet the criteria of focusing on reducing health inequalities, then we won't work on it. Doesn't mean to say it doesn't need doing, but we won't be able to work on it.
Thank you. And just to let colleagues know that there was some work underway before COVID to develop a musculoskeletal dashboard as part of that whole systems integrated care dashboard for North West London. I'm going to move to our last speaker, Mr. Mike Turner, who is the Chief Operating Officer at Connect Health, who's going to look at some of the challenges and lessons learnt in making and embedding transformation as a private provider in collaboration with the NHS. Mike.
Thanks, Ian. First slide, please. So just to set the context, just briefly in terms of who Connect are. So we provide community MSK services, integrated MSK services, including pain and rheumatology, 26 of those services across England, and we look after about 350,000 patients a year. But about 15 of those services were launched in the last 4 years, and a number we deliver in formal partnership with NHS organisations. Next slide, please. So I think helpfully the things that we reflect on as lessons learned both before COVID and in dealing with COVID and thinking forward are very similar to what we've heard about today. Probably 3 key ingredients really to achieving sustainable transformation. First of all, common purpose. We've heard a lot about infrastructure, and then method for making the change, which is what I'm going to talk a bit more about today. Next slide, please. So common purpose, and I suppose I'm meaning by that strong relationships and aligned objectives. Again, we've touched on it quite a lot this afternoon. Just briefly, I mean, traditionally where we have been commissioned to provide services, often the backdrop to that has put us in conflict with potential partners in a system, in that we've been brought on board to often reduce the flow into orthopaedics, but where there are PBR tariffs. We've often bid in competition with local providers, and therefore we are set up as competitors rather than collaborators. So there's that confrontation, and it's clear that success doesn't require that. Success is about partnership and collaboration. And I think, as we've heard this afternoon, one of the potential positives in the way that we've responded to COVID is there's lowering of the boundaries, and I think stimulating conversations and engagement both within and across organisational boundaries. And I think that's a key lesson learned to take forward for recovery. We work in partnership, so an example there with Northumbria Healthcare in delivering an MSK service. And probably one of the things that stands out to us that it was helpful in setting us up to cope with the impact of COVID was that the service was co-designed between the two organisations and was already co-delivered. And as we responded to the changes we needed to make, those themes of co-design and co-delivery continued. And what was really striking is the recognition that the complementary capabilities of, in that case, our two organisations, but clearly this is across health systems, the complementary capabilities, and therefore the ability to deliver that 1 + 1 = 3, greater than the sum of the parts, is key. And it's really consistent with where we were going anyway, aside from COVID, in terms of integrated care. But I think that common purpose and shared objectives is clearly key. Next slide, please. So the next area for us is infrastructure. So again, mentioned a lot, digital tools and things. One of the focuses we've had for some time is trying to establish services and use tools and techniques that really build patient engagement and support self-management. So that foundation has been very helpful to us, and certainly clinicians working in our MSK services were more familiar and more comfortable with working remotely because it was already established. But what we did find during COVID is it provided both the impetus and the opportunity to push some of those things further forward. So we introduced additional digital tools that allow patients to enter the service, provide background information, and speeds up their interaction with a clinician, supports stratification of patients and risk assessment, but particularly introducing things like virtual seminars and groups, over video technology. What's been really positive and a really important lesson learned is how well patients have responded to that. We've had really great feedback and great uptake of those. So there's definitely something in going forward around that balance between, it's not all about digital, but it absolutely does have its place. And I think we've got used to that quite quickly and implemented it quite quickly. The other key point around infrastructure, and again, it's been mentioned this afternoon, is around data. So I think having having good real-time data so that you can see what is happening at any point in time, for me, is key to transformation and sustaining that transformation. So whether that be about referral patterns, clinic utilization, DNA rates, patient outcomes, whatever it is, having that data so that you can monitor what's happening and respond quickly to things not being as you expected, a key enabler. Next slide, please. So then the third ingredient was around methodology. So I suppose we would typically approach when we're launching a new service with a three-stage process that inevitably has a planning stage, implement, and then we expect to go into that continual review, refinement, and continuous improvement of the service. I don't think any surprises in that, but I think certainly in the response to COVID and as we think forward, there's a few points that particularly I think jump out. First of all, having multidisciplinary teams. And I think, as was mentioned earlier, that's beyond just clinicians in terms of multidisciplinary, but also involving operations, IT, HR, governance, other colleagues. And certainly we found it was very successful getting those groups of people together, working through what changes were needed, what are the implications, what do the right solutions look like as an integrated team from the start. I think the other thing, perhaps unsurprising also, is make sure that there is a focus on people, that being patients, but also our colleagues delivering services. What support might they need to work through the change? What tools do they need? What does communication look like to keep everybody engaged and informed? And how do they actually contribute and drive that change? Clear ownership and accountability. Again, I think Mary was talking about that as well. Clear to making sure that things get done and done at pace. Everybody knows what they need to do. But I think probably something that we learned and have developed more through COVID and would wish to take forward is this idea of being more agile in our approach to implementing change. So rather than lots of analysis and preparation and being assessing something as perfect to go, is actually being prepared to trial things at small scale, check that they're safe and effective, and then roll out and accept that actually developing them over time, continuously improving them, they don't have to be perfect from day one, has actually been a really positive way to work. And I think has encouraged that engagement of colleagues and that sense of purpose and drive that we've heard about this afternoon. Next slide, please. So briefly on this slide, this was just an example to illustrate. So this is that Northumberland service that I mentioned, which has been running for about a year, a community MSK service, and therefore a part of its journey before COVID and a part with COVID. I think the thing that we take some confidence and assurance from is through that journey, the fact we've been able to maintain positive prems and proms and good operational metrics in running that service. But probably key thinking about the challenges we face going forward is that service has faced 20% more referrals, even with the impact of COVID in the last 4 months or so, than it was expected to. But we've yet managed to deliver the good outcomes that we're looking for while what we're delivering less than more than a 30% reduction in appointments. So I think in terms of that real effective use of the capacity we have to meet demand and get good outcome from patients, I think there's definitely some things that we're learning from the way we've done that. Next slide, please. So then finally, really this is then as we start to think forward, I suppose we've kind of got 7 elements that are in our mind as we think about recovery of our services and restoring our services. The 2 sort of markers on there that are in these sort of amber type colour are the things that are absolutely new in response to COVID, obviously the symptom checker, but also that approach to stratification at the front of the pathway. And I think that talks to what Sir Jim Mackey mentioned earlier on as well, about it's not all about digital, but you need to understand what each patient might need. So making that decision early. And in fact, digital tools can potentially support that. That's what we're learning, but making that decision early. But then having a balanced model that uses those virtual tools where they are appropriate and uses that for flexibility and capacity while reintroducing face-to-face and having a balance with still some clinicians working from home because we get some of those productivity benefits that James mentioned. So for us, it's kind of making sure that we're balancing all of those needs and weighing them up over time, but with the aim of making sure that we maintain as much flexibility while creating capacity in the services we can. Thank you.
Great. Thank you very much, Mike. That's absolutely brilliant. We've got about just over 5 minutes left for to go through the questions that are coming through on the chat. Some of the questions have been answered directly, so I'm not going to go through the ones that have been answered, but I've got one question I'm going to invite all our speakers to discuss. And I'm hoping we've got Graham Wilkes, who's the Chief Medical Officer at Connect. I don't know if he's able to help join to field some calls, some of the questions as a clinician. So the question is this: there's a huge pressure on return to face-to-face appointments, and the UK is certainly behind some European counterparts in terms of opening our services back up again. And there's a huge frustration both from clinicians and patients that it's still incredibly difficult, even where it's clinically indicated, to get a face-to-face appointment. There just seem to be so many obstacles. So I'm going to start with James. What's your roadmap to opening up where it's appropriate to do so? What's your roadmap to opening up to not the domiciliary, going around London on a tandem bicycle with the district nurse behind, but getting the clinics back open again? What's the roadmap?
So our clinics have opened up as of this week. Our surgical services and our dental services have opened up, and pediatric surgery has opened up, which is, I think, really interesting in terms of the way that works as part of relieving pressure for acute. I think we need to balance this. We need to be very clear about how we communicate our waiting times with patients, and Dinesh sort of identified that in his speech. But we've got to consider the environment. More people travelling, coming to services, drives fumes, it drives the atmosphere and reduces the health of our population. So we've got to think, why are we getting people to come to us? Because coming to us could make them unwell, not just from COVID.
Great. Okay, so Dinesh, what's your roadmap for increasing the capacity for outpatient face-to-face appointments where that's clinically necessary?
Okay, so I think the world has definitely changed. When we did an analysis on our site, we found that there were over 1,100 appointments, face-to-face appointments per day within our trust, on one of the trusts. And if those patients are coming accompanied with a relative, you've got 2,500 people coming into the hospital where there is still a risk of COVID. And so our focus has been to try and create COVID protected pathways within the secondary care system, which has been a real challenge. I do think that the digital offering that we've talked about is here to stay. Mirav mentioned our virtual fracture clinic, which we successfully implemented, and we now have 70% discharge rate with that virtual platform with fracture clinic patients, which is an extraordinary achievement when you compare with the rest of the country, which is running around 30 to 40%. And I think the difference has been to match senior clinicians with patients. They need to hear from consultants. And so every patient got a phone call from a consultant, which reassured them that this was the right decision for them. So obviously the pathways are in place to try and make it as green as possible, and it will come in the next few months, but I don't think the numbers are going to be anywhere near where we had them before.
Great, thank you. Graham, I think, are you there, or are you leaving for another call?
Yeah, Ian, I do have to leave in a couple of minutes.
So quick word on opening up at in community services. MSK, very hands-on. How are we going to do it?
Yeah, I think historically we probably have all done too much hands-on, and I think one of the lessons learned over the COVID period is how successfully we have managed to help patients without the hands-on and the face-to-face. Having said that, what we don't know is if there's going to be a backlash in terms of patients wanting to become face-to-face. I dare say we haven't changed culture at all yet, but I think there is clearly in the public an awareness now of digital. So I think we know self-management is a key aim in musculoskeletal care, and it can be achieved without face-to-face. So I think we've just got to keep working with patients, with patient groups, with our colleagues. And I think the key thing is to get the data and the outcomes to support a different approach. And that is really going to be key. I think we shouldn't do anything without the data to support it. I suspect we can do a lot more digitally and without face-to-face, but we really need to study that.
Great, thank you very much, Graham. And I think the nugget for me, which I'm going to reflect with Mike, the nugget for me really is around managing patient expectation. And that also means managing primary care clinicians, GPs like myself, about what is and isn't possible, and where the evidence lies. Most primary care clinicians are not experts in musculoskeletal health. It's a very small part of our training. So how do you see, how can we actually change patient expectation?
So I don't think there's kind of one easy answer to that, but I think yeah, I think that integration with primary care, I think is key, and I think that is one of the things that we've seen during COVID is a greater, notwithstanding the pressures and the challenges, but a greater openness to consider these different ways of working. And I think what I pick up on what Graham says. I think our experience has been that patient expectations have changed, not for every patient and not fully met where we might think that they could and should go to, but actually there's been that watershed moment. Certainly the feedback we got in the early weeks was that patients were delighted to have a remote consultation, feeling that the alternative would be nothing. And actually they saw the benefit in that. And I think even now, whatever we are, 16 weeks in, that feedback is still being received. So I think we're on the journey. I think it's just keep there. The risk to me would be if we let ourselves just regress, because it might feel easier. I think it's about holding the line while still considering what's most appropriate for patients.
Fantastic. I want to just change topic to something we touched on earlier. There was a very interesting slide that Dinesh showed about he called it the tsunami that was waiting to hit secondary care. Now, why is this important? Well, although surgical care affects maybe 3% of patients who have NHS healthcare for their musculoskeletal health, it consumes over 50% of the programme budget for musculoskeletal health. So we can't ignore it. Although it's a small number of patients, it's a huge expense and it has knock-on effects if we don't get this right. So there was some very interesting things on the chat about actually re-evaluating patients who are on waiting lists about whether they could indeed be managed conservatively. So I can see Marav nodding there. So Marav, do you want to expand on that?
I absolutely think we should be doing that. And we've started to do it in quite a lot of our other services, which is just to, for senior clinicians to be looking at the patients on our waiting list. And we have to remember, and I just want to reinforce what our previous speakers have said, which is that we have eye-watering backlogs. We do not want, patients do not feel, we know they've told us they do not feel safe coming into hospital. We've got a high proportion now who are cancelling their own appointments even when they need them. We have, as Dinesh said, made our hospitals as safe as possible by separating pathways. And therefore, we need to make sure that the patients who we treat and see are those who are most in need. And in order to do that, that requires us essentially triaging our waiting lists.
Okay, so I'm going to ask Dinesh now. If Marav asks you to triage your waiting list, what does that look like in practice? I mean, how many patients have you got to review? How does that get done? What happens to those patients? Just talk us through what that looks like.
At Imperial, we've already done this process. The Royal College of Surgeons sent out a surgical risk stratification, P1 to P4 classification system, and we have over 1,000 patients on the waiting list. Every single one of those patients has now been stratified according to those parameters, and also an identification of the harm that will be put on this patient if they were to wait longer than the P1 to P4 time parameters that the Royal College of Surgeons has done. So that's all electronically done, and every 3 months we've been asked now to review our waiting list and make sure that those stratifications remain in place. It is difficult. Most of the MSK elective work is a P4, which isn't high priority, if you like. P1 and P2 are the fractures, and P4 will be the joint replacements and the bunions and everything else. But the cancer care has to come ahead of those kind of patients, especially with limited capacity. as hospitals start to reopen. So the triage process has been executed and successfully executed in our trust, but it's been very difficult to take people off the list because they do have debilitating conditions. So I'm not sure that it will be very easy to take a 30% slice off the waiting list and put them back into the community. I don't think that's fair on the patients.
Okay, so I'm just going to tease you a little bit because I can do that. There's often more than one way of doing things, and for sure there'll be a large cohort of patients where a decision has been made that surgery is the right thing. We know that it produces a step change improvement in quality of life, never mind the expenditure, it's cost effective. But there'll be some patients who there's a balance, and maybe they chose early on to go for surgery because their friends had surgery and whatever, and they don't like exercising because it takes a lot of effort. So maybe there could be 5 or 10%. I'm just looking at the chat. One of our colleagues thinks that about 5% of people that they've reviewed on waiting lists could actually be managed conservatively. It's a help. That's how could we identify those 5% and offer them a realistic conservative option?
Well, I think the only way to do that is to have another consultation with the patient and give them the choices that they have. Because yes, they were on a waiting list for surgery, but things have changed, the world has changed, and as long as you have an informed patient who is happy to go on a different pathway, I don't find that unreasonable at all. But it will be time consuming. It means to actually review and telephone every single patient on the waiting list, which across the country is going to be a huge burden, considering we still have referrals coming in. So it will be a difficult thing to achieve. I think 5% sounds reasonable. I wouldn't disagree with that number at all. But
so in terms of trying to make things easy, because that's the name of the game here, is it possible? I'm going to ask James and Mike as community providers. Is there scope for the community providers to perhaps have that conversation if the patient is willing to do that? Because we know that secondary care is really time constrained. So James first.
I think there's no reason why not, as long as it's sitting in an agreed MDT pathway along that specialty line. So I think it does need to be the right people. And when I think about MSK, the vast proportion of MSK services are integrated in some level between primary, community and acute care. So I think there's nothing wrong with doing that. And we can probably start to look at whether or not we can provide some additional type of intervention in the community.
Great. And Mike?
Yeah, I would second exactly what James has said, and in fact, we've agreed with one of the trusts that we work with to do exactly that, to do that as a joint review, and then that clinicians in the community service will make those calls to get that underway.
Great. I'm just going to go to Ali just to check if there's any other burning questions that I've not seen on the chat. Ali, if you're able to open your mic and just let me know.
I think most of the larger questions have been covered. It's little things, well, not little, but questions like the virtual clinics and how they work, how they'll work in the future and things like that. But what I'm suggesting is we have a look at all the questions that have come through. There has been a lot, been about 30. So, and we perhaps put a Q&A together after the event and publish that on the website and send that round to people.
Thank you, that's fantastic. Well, it just remains me to thank all our colleagues, Sir James Mackey, Mr. James Benson, Mr. Dinesh Nathwani, Mrs. Marav Dover and Mr. Mike Turner for your insights today. And we look forward to seeing all our colleagues at the next webinar. A big thank you to Connect Health for putting this on and the infrastructure and getting everybody organised. Thank you very much.
Thank you.
Thank you.
Great. If I could just ask our speakers if we could go